So let's see the first question. Okay, let's see what all the, and I want you to answer also. Okay, whatever you think is the answer, just let me know. We'll discuss. 56-year-old female with T1N0 invasive ductal cancer of the left breast, which is ER positive, PR positive, and HER2 negative, undergoes lumpectomy with a sentinel node biopsy. Pathology tells that there is 1 millimeter caudal margin and confirms that no lymph node involvement is there. 21 gene assay recurrence score is low, 8. Which of the following describes the next best management? Okay, so now let's see. This patient with a early breast cancer, she underwent lumpectomy. Okay, lumpectomy is breast conservation surgery. So when we do breast conservation surgery, suppose this lump was removed. Now they say that 1 millimeter caudal margin means lower margin, the tumor nearest tumor cell is within 1 millimeter. So no ink on tumor is considered as negative. Okay, so this will be considered as negative margin. So there is negative margin, no lymph node involvement. 21 gene assay is oncotype DX. Oncotype DX. Okay, which is a 21 gene assay which will predict the likelihood of the tumor recurrence in that particular tumor. So usually the score less than 26 is low risk, more than 26 is high risk. So patient is having low score 8. Which of the following describes the next best management? Re-excision of the caudal margin is not required because you have enough. 1 millimeter is more than enough. 1 millimeter margin is enough. Radiation therapy and endocrine therapy. See, in case of breast conservation without radiation, it is incomplete. Endocrine therapy you have to give because it is ER/PR positive. So this appears to be the correct answer. Let's see the other options. Okay, I deliberately put 5 options so that we can discuss more possibilities and we can rule out more options. Okay, I know in your exam there are 4 options, but I deliberately put 5 options. Chemotherapy is not required because in this case the oncotype DX score is low and patient is early breast cancer, no lymph node, so we can easily avoid chemotherapy. Radiation therapy alone, if the patient is ER/PR positive, no matter what, you have to give hormonal therapy. Endocrine therapy alone, in case of breast conservation, it is not complete without radiation. Okay, so that's why option number B is correct. Okay, all of you agree? If there is any confusion, any doubt or anything which you don't understand, anything on which you and me are not agreeing, please let me know. Okay, this is a discussion class. Okay, these are the things which you have already read. It is just we are trying to see the question and trying to approach a clinical based question. So anything you can ask me. Okay, so I hope, see, the basic purpose of these classes or these sessions are if you have read the topic. Okay, otherwise, it's not possible for me to teach you in these 2 hours the breast, thyroid and parathyroid topics, which will take like more than 10 hours. Okay, if we read it for the first time, it will take more than 10 hours. So we cannot do that. So that's why this session is basically if you have read it, and now we are discussing the question, and if you find it difficult to understand the question, then I can tell you. Okay, so those who are, why radiation therapy is needed here, Adrija? Yes, these kind of questions, because we have done a lumpectomy, means we are doing a breast conservation therapy. Now in breast conservation therapy, 3 things are required: the surgery, that is lumpectomy, the axillary assessment, like in this case axillary lymph node assessment, like in this case sentinel lymph node biopsy was done, and third thing is radiotherapy. If any of these 3 things are not possible, you cannot do breast conservation therapy. Negative margin, Munish, yes, I'll tell you. See, suppose this is the breast and this is the tumor. Okay, so now when you are doing a lumpectomy, clinically when you do a lumpectomy, you take from your side at least 1 centimeter margin. Okay, you palpate the tumor, you do the marking and take 1 centimeter margin and take it out. 1 centimeter margin. So suppose now this is your specimen. Now you will send this, you want to see this specimen under the microscope. Okay, so you take the help of your pathologist colleague, and now when they see it under the microscope, they can see those microscopic tumor cells also, which you cannot see grossly or you cannot see with your eyes. So suppose the cells are like this. If it is not present on the margin, okay, you can say no tumor on ink. Margin is ink, means when you put that specimen into the pathological ink. So no tumor on ink is negative margin. Even if the tumor cell is very close, even if it is 1 millimeter, it is still negative. But if the tumor cells are present here, okay, tumor on ink, that is positive margin. Okay, that is positive margin. Okay, so this negative and positive margin, no tumor on ink and positive margin is tumor on ink, this is for invasive ductal cancer. For invasive ductal cancer. For ductal carcinoma in situ, positive margin is if the tumor is on ink or within 2 millimeter of the margin. If the tumor cells are present within 2 millimeter, that is also considered as positive margin. Negative is when the tumor cells are more than 2 millimeter away from margin. Why not chemotherapy? Okay, Sakshi, what you are saying, that is correct. See, for chemotherapy, the standard thing is what, like Sakshi is saying, if the tumor is more than 1 centimeter or if the axillary lymph nodes are positive, then we have to give chemo. But these days there are new multi-parameter gene expression analysis tests, like there is something known as oncotype DX test. So oncotype DX test we can do at this moment. Currently we can do for T1, T2 patients with either N0 or up to 1 to 3 axillary lymph nodes positive. Up to 1 to 3 axillary lymph nodes positive, we can go for oncotype DX test. So in this test, they will check 21 gene in the tumor. Okay, they see this PCR technique and they predict the likelihood of cancer recurrence. So on this test, if there is low score, then chemo may be avoided. You can avoid the chemo. High score, like more than 26, you have to give chemo. Okay, so this is something new, oncotype DX. In our classes also we discuss this like frequently. We in all the classes we have discussed about oncotype DX, that those people who can afford these tests and they belong to this category preferably should also be ER/PR positive. They can get themselves checked for this oncotype DX, and if they come out, if it comes out to be low score, then you don't have to give chemotherapy in these cases. Okay, the chances of recurrence will be less. So that's why option number B is the best answer. Okay, you have to give radiation because you are doing a breast conservation therapy, and endocrine therapy, that is hormonal therapy, you need to give because it is ER/PR positive. Okay, going to the next question. 50-year-old female. In class also the score, I don't know which classes you are talking about, it is 26 only. Okay, so although the score is not that important, the exact value, less than 26, more than 26 is considered. In younger patients, even there are 3 values, less than 18, 18 to 25, more than 25, but You don't have to remember this 36 as such. Just remember that low score you don't have to give chemo, high score you have to give chemo. Okay, the value is, this is like at present today, if you ask me, it is 26. Okay, today, like because there are so many changes happens in this you can say the values and all, and in breast cancer the changes are very frequent. Okay, so less than 26, more than 26, where I was saying it. Yes, this is for post-menopausal. Okay, if you want to know the correct recommendation for post-menopausal. For pre-menopausal, like I said, less than 15, low risk, 16 to 25, moderate, more than 25, high risk. This is for pre-menopausal. Okay, that is oncotype DX as per the, like today, if you ask me, like current recommendation as per the NCCN, this is the recommendation. Okay, so this is the latest or current recommendation as per the oncotype DX. Okay. Next question. 50-year-old female and complaining of generalized non-focal cyclical breast pain in her left breast. Her clinical breast examination is normal and she has a negative screening within the past months. You advise her that. Okay, so patient is having cyclical mastalgia. Cyclical mastalgia, which is very commonly seen in fibrocystadenosis or fibrocystic disease. Fibrocystadenosis or fibrocystic disease. Yes, Adit, Dharti, and very proud of you guys. Okay, you are doing these. I have taken the questions which are like clinically important, and these are not very easy questions. Okay, so in fibrocystadenosis or cyclical mastalgia, in fibrocystadenosis there is cyclical mastalgia with or without nodularity. Nodularity can also be seen. There will not be any proper lump. That is, question is also saying that there is no lump as such. Cyclical mastalgia, usually the pain starts on 14th day of the cycle and increases till the periods, or till when the bleeding occurs, and then it subsides. Again on the 14th day the pain will start and then it subsides. Okay, so that is the typical presentation. This is a you can say this is an estrogen dependent condition, which as the age progress it will become better and better. So breast pain is frequently associated with breast cancer. That is not true. Breast cancer is mostly starts as a painless lump. Oral contraceptive are not associated with breast pain. Oral contraceptives can increase the breast pain. Okay, oral contraceptive, there are reports that it can increase the breast pain. Pharmacological agents are not recommended. They are recommended pharmacological agents, certain like drugs like danazole or meloxifene, even tamoxifen. They are also like there is evening primrose oil. Okay, so they are recommended. The fit of her bra is an important consideration as the cause of breast pain. This is correct statement. Okay, the more the breast will hang and the more ill-fitted or loose bra or very tight bra she will use, the more pain will occur. Okay, so if she is using a padded bra, sports bra and a well-fitted bra, it significantly decreases the pain of the patient. The breast pain is not very responsive to treatment. It is responsive. Okay, so it's not like that it is not responsive to the treatment. Okay, so this was a straightforward, easy question. All of you had, answered it correctly. Next question. Which of the following is true regarding the radiotherapy for the treatment of breast cancer after breast conservation? Okay, so they are talking about in the breast conservation therapy, when should radiotherapy be given. Radiotherapy should be performed even if no lymph nodes are positive for cancer. Okay, so this is the correct statement. I told you that you have to give radiotherapy in the breast conservation no matter what. So even if lymph nodes are not positive, then also you have to give radiation. Radiotherapy is recommended as treatment for a positive margin after lumpectomy. See, after lumpectomy, suppose you have done a lumpectomy. You have done a lumpectomy and this is how you have done. And now the margin comes to be positive. So if it is positive margin, then what you are supposed to do is you go again in this area. Suppose this is the part you had removed. Now you will remove a little bit more from this side. You have to remove more. Okay, so you have to re-excise, or you can say the better term they use is cavity shave. You have to re-excise. You go in that area where the tumor was there, so that is known as tumor cavity, and then you have to do a cavity shave. Take a little bit more margin, maybe 5 millimeter or 1 centimeter, and do a cavity shave. Okay, so radiotherapy, so anyways you have to give, even if the margin is positive or negative, that doesn't matter. You have to give radiotherapy if you are doing a lumpectomy. Whole breast radiotherapy is more effective when given concurrently with chemotherapy. That is not correct. Okay, chemotherapy is not required in all the cases of breast conservation. Only in those locally advanced cases chemotherapy is given. Otherwise, it's not recommended. Radiotherapy is less efficacious with small tumors compared to larger ones. There is no size criteria as such that if it is a small tumor the radiotherapy will be more effective, or if it is a large tumor it will be more effective. There's nothing like that. Higher energy radiation exerts more damage to the skin. We are not worried about the skin damage per se, but yes, higher energy radiation can cause damage to the underlying structure. There is heart, there is lung, so those organs are more susceptible to the damage from the radiotherapy rather than the skin per se. Okay, so A is a very clear cut true option, and a very you don't have to think twice in this. A, radiotherapy should be given even if no lymph nodes are positive for cancer in a breast conservation therapy. Okay, so two types of radiation you can give. Suppose this was the area where the tumor was there. So after breast conservation you can give either radiation to the whole breast, that is known as whole breast radiotherapy, or you can give radiation only in this area, that is known as accelerated partial breast, or you can say this is known as partial breast irradiation. Partial breast irradiation, because see why we are giving radiotherapy in a case after lumpectomy, because you have not removed the complete breast. You have just removed the tumor and just a little bit of tissue around the tumor. So if the cancer has to occur, it will occur from that area only from where you have removed the tumor. So if there is any possible microscopic tumor cells are left, those will be left in that area. So that's why if you give radiation in that particular area only, where you can call it as a tumor cavity, so that is also equally good. So that's it. That is partial breast irradiation. It avoids giving radiation to the whole breast or to the whole chest. Okay, so yes, partial breast irradiation, you are correct, Santhia, can be given as accelerated or can be given as intraoperative. Okay, it can be given as accelerated partial breast irradiation or intra-op partial breast irradiation. Accelerated can be given as external beam radiotherapy, or it can be given as brachytherapy, in which you can put a multiple catheters or a single entry brachytherapy device. Yes, Pooja Kumari, very good. It is given to prevent recurrence. Okay, next question. See, read the question. This is what I want you to want to make you understand, that in this clinical case or clinical scenarios, you have to read the question very carefully. After a modified radical mastectomy, the female reports new onset weakness of the ipsilateral arm when pulling down on a cord to adjust the blinds in her home. Okay, the blind. She is like pulling down the blinds, and during that she is having, a weakness. On examination, she has difficulty when attempting to internally rotate and adduct her arm. What is the best explanation for her deficits? So after the MRM, certain injury has occurred. Now see, all these nerve injuries can occur. Intercostobrachial nerve can occur, long thoracic nerve injury can occur, thoracodorsal, supraclavicular nerve does not injure, medial pectoral nerve. So all these nerve injuries are seen in, or there are possibilities after the modified radical mastectomy. Intercostobrachial nerve, it is a lateral cutaneous branch of the second intercostal nerve. The injury will lead to loss of sensation on the medial arm, medial aspect of upper arm. Long thoracic nerve will cause winging of scapula. I am sure you know this, winging of scapula. Medial pectoral nerve injury will cause, there will be atrophy of pectoral muscle. Transection of thoracodorsal nerve. See, thoracodorsal nerve supplies latissimus dorsi, and latissimus dorsi causes what? It causes adduction, extension and medial rotation of arm. And this is the problem. Okay, she cannot do the medial rotation and she cannot adduct her arm. So basically she had injury of thoracodorsal nerve. This is also fine. This is not a very debilitating type of injury. But the problem is, if the thoracodorsal nerve injury occurs and you want to use a latissimus dorsi flap for the reconstruction, then it is a major problem. Okay, because it will cause atrophy of that LD flap. So then in those cases it is a more problem. Okay, so that's why the answer here is C, transection of the thoracodorsal nerve. Okay, so see, medial pectoral nerve is present. You need to remember this. There are two nerves which are supplying the pectoral. There is medial pectoral nerve and there is lateral pectoral nerve. Now medial pectoral nerve is present laterally and lateral pectoral nerve is present medially. Okay, and when we are doing the surgery in the modified radical mastectomy, when we are doing the axillary dissection, so that time medial pectoral nerve injury medial pectoral nerve is more prone to injury as compared to lateral nerve, because lateral is present medially. We don't go very medially in that higher up. Okay, so C is the answer. Next question. See the question. 35-year-old female, burning pain and redness along the anterolateral right breast. Firm tender cord could be palpated just below the skin towards the lateral breast. Which of the following is true regarding the initial management of this disease? Now you tell me what is your diagnosis. First you tell me what is your diagnosis. All of you, what is your diagnosis? This is very easy. Okay, pain, redness, tender cord-like structure. What is it? What is it? It is a Mondor's disease. Okay, this is Mondor's disease, superficial thrombophlebitis. Superficial thrombophlebitis. Yes, you are correct. Usually the nerves which the veins which are involved are lateral thoracic vein, thoracoepigastric. These two are mainly involved. Sometimes, rarely, the superficial epigastric can also get involved. Superficial epigastric. So see, Mondor's disease, the cause is it is usually a inflammation. That can be due to maybe sometimes a trivial trauma, sometimes it can be because of lifting heavy weight lifting. Sometimes the underlying malignancy can also lead to this. Treatment is just give rest, NSAIDs, hot compresses. So now see, systemic anticoagulation, which most of you are saying, that is not correct. Okay, it is not a thromboembolic phenomena. It is not a blood hypercoagulability disorder for which you will be giving systemic anticoagulation. Systemic anticoagulation means you are giving IRL injectable anticoagulation like low molecular weight heparin, or you are giving warfarin. We don't have to give this. This is just a local inflammation, and because of that the vein got thrombosed. Antibiotics covering gram positive, it is not an infection. Why will you give antibiotic? It is not an infection. Short course of oral corticosteroid. Steroids are not orally, nothing you have to give in this case. Only thing you can give is NSAIDs because of pain. Biopsy is not required. Okay, so the only correct option is mammogram or ultrasound to rule out if there is any underlying malignancy. Okay, so A is correct. Rishabh is saying how to differentiate from inflammatory breast cancer. See, in inflammatory breast cancer there is, what is there? There is redness along the anterolateral right breast. Okay, lateral right breast, just below the skin from tracking out towards the lateral breast. This is what they are saying, that there is redness along this part. Usually this is a lateral thoracic vein. What happens in inflammatory breast cancer? In inflammatory breast cancer, you will see podgy orange appearance in more than 33%. There will be erythema, edema, tenderness in whole of the breast, not in a particular area. This is very focal. Okay, this is a very localized thing. Steroids, see, if you get a Ayush, when you get like suppose you get some blunt type of injury, do you take steroids for that? Okay, which I mean, steroids are not giving for any inflammation. Steroids, who gives steroids for any inflammation? Those people who are like in the village, who are like sitting quacks, and they give steroids very frequently. Okay, we as a doctor, as a proper doctor, we don't give steroids just for simply inflammation. If there is any chronic thing, any autoimmune thing, then in those cases, yes, it can be given. But just for a thrombosis of a vein, you will give steroids. That is not justifiable. Okay, so that's why A is the best answer in this case. Going to the next question. 44 year, if NSAIDs was an option, then what will be the answer? Which of the following is true regarding the initial management? Okay, if suppose you are saying NSAIDs, then there will be two correct options. Okay, there will be two correct options. There are multiple options correct also. So you see, even if NSAID is there, in the initial part, you have to rule out this. Rule out malignancy if it is, if this disease is there, Mondo's disease. That's just steroids which you are giving for TEAT syndrome, NEET PG 2024. That is given as locally injectable in the form of triamcinolone. In that case also, we are not giving oral steroids. Okay, we don't give oral steroids for TEAT syndrome. We'll give intralesional steroid in that case. 44-year-old female, palpable, tender, mobile mass in the upper outer quadrant of the left breast. The overlying skin is normal and there is no adenopathy. Ultrasound reveals 2.5 centimeter cystic lesion. Ultrasound guided cyst aspiration is performed. Which of the following is true? So this question is about the breast cyst, which usually occurs in the age group of like 40 to 55 years, and usually it is not seen in the postmenopausal patients. Now the breast cyst is Generally it is not a big problem. Okay, if it is not causing anything, if it is just incidentally discovered, then you can leave it also. But suppose if it is causing pain, then you do the aspiration. The fluid should be sent for cytological examination only if it is blood tinged. That is true statement. That is true. Straw colored fluid should prompt a co-needle biopsy. Straw colored fluid is fine. Co-needle biopsy you should do if it is blood or if it is having some solid component, or you should do if there is thick walled, then you should go for this co-needle biopsy. The presence of septation is associated with low recurrence. If there is septation, just imagine there is a cyst and there are septations. Now you do the aspiration. So in which case the chances of recurrence is more. Obviously, if there are septations, you will not be able to aspirate the whole thing and there are chances of more recurrence. Okay, so that's why this is incorrect. Thickness of the cyst wall does not correlate. Like I said, thick walled, there is risk of malignancy. Viscous gel-like fluid can be seen. It is a feature of benign condition. So if there is blood, if there is solid component, if there is thick walled, if there is recurrence more than 2 times or within 2 weeks of aspiration, these are some of the indication which will make you suspicious that maybe you are dealing with a malignant type of cyst rather than a simple cyst. So you will take biopsies in these cases, co-needle biopsies. A solid component only is the complex cyst. Cyst and fluid solid component is complex cyst. So recurrence more than 2 times, or if the recurrence occurs within 2 weeks of the initial aspiration, these are some of the indications for doing the biopsy. So yes, option number A is correct. If the fluid is blood tinged or blood, then you should send the aspirate, you send that fluid for the malignant pathology, and also you take the biopsy. Excise the cyst is ceremony, the same thing is you see when you are doing a co-needle biopsy. If it is inconclusive, then you can go for excisional biopsy. Okay, so in these cases, initially you don't have to do excision of the cyst. If it is a simple cyst, then you just do aspiration. Okay, if it is suspicious, then you take co-needle biopsy. Suppose co-needle biopsy is not conclusive, then you do excisional biopsy. Or suppose there are more than 2 times recurrence, it is benign but it is causing significant discomfort to the patient. So one of the option is patient's choice. If the patient wants you to get it removed because she is like fed up because of the multiple recurrences, then in those cases you can go for excision. Okay, otherwise as such the treatment of choice is aspiration only. Next question. Nipple discharge is most suspicious of breast cancer in which of the following females? Okay, 35-year-old female with bilateral brown discharge. Bilateral, brown. Both are features of benign condition. That is only visible on squeezing. Okay, so this is absolutely benign condition. Probably because it is brown, so probably it is duct ectasia. 45-year-old female, unilateral, serous, spontaneous. This is suspicious. Okay, so this suspicious discharge, you can say discharge suspicious of cancer. They say 4S. 4S. Single duct, spontaneous, serous, sanguineous. and okay, that is fine. Unilateral you can add, but let's we have written single duct. Single duct, spontaneous, serous or sanguineous. Sanguineous means bloody. That is suspicious of malignancy. Okay, why you are saying a CC? Okay, this is confusion. Lactating female, unilateral blood discharge is physiological. That can be normal. Okay, so this is very much clearly written in the book that during breastfeeding sometimes a little bit of blood discharge may come, and that is absolutely fine. You need to reassure the patient that that may happen. Okay, so that is normal. That is normal. Okay, so this is normal. Option number C is normal. 50-year-old female, greenish discharge bilaterally, sometimes spontaneous. So again greenish, it is duct ectasia. Brown, black, green, duct ectasia. Bilateral milky discharge that occurs spontaneously, that is also normal. That can occur because of increased prolactin. I mean, it is benign, you can say, not normal, so you can say benign. Galactoria can be the reason of milky discharge. Okay, so the only option which is fitting in the malignancy is unilateral serous spontaneous discharge. Even if it is bloody, that is also fine. Sanguineous means blood. Okay, so remember this thing, in pregnancy, in pregnancy or during breastfeeding, nipple discharge, a blood nipple discharge may be seen. It is not something which one should be, alarmed or one should be worried about. Fine. Okay. Going to the next question. How to know single duct by history? No, Rishabh, you will not know single duct by history. You have to do the examination. Okay, to know that whether it is single duct or multiple duct, it is examination. And usually when the patient is intelligent enough, if they are like literate, they will tell that that doctor, the discharge comes only from a point. Okay, that patient will tell you. You can ask the patient that whether the discharge comes from a same site every time or it is coming from the different areas, because it is patient's body. She knows her body much better than you, maybe as a doctor. She knows her body much better. Okay, so she will tell that no doctor, every time it comes from the same spot. Okay, and if she says no, sometime it comes from here, sometime it comes from there, sometime it comes from above, sometimes from below. So she will tell you this in her history also, and you can confirm this. Suppose you are not very sure about the intellect of the patient, or maybe you're not sure that whether she's understanding you or not understanding you, then in that case you can do the examination also. But believe me, most of the patient, at least this thing they can tell. Which of the following is most characteristic of a malignant lesion as seen on the ultrasound imaging? Okay, so malignant lesion, I told you, usually it is solid, hypoechoic, taller than wide, asymmetric, heterogeneous, and microcalcifications can also be seen. Bilateral edge shadowing is a benign condition. Homogeneous means everywhere it will appear same. It is also a benign feature. Anechoic means cyst. Anechoic means cyst. Hypoechoic means mass. But this mass can be benign. Even fibroadenoma will also look hypoechoic. The other benign conditions will also appear hypoechoic. Taller than wide measurement is the answer. Taller than wide suggests that there is infiltration. It suggests infiltration. and infiltration is seen in cancers. Infiltrations are seen in cancer. Okay, so these are the features suggestive of malignancy and tolerance. Among all these, although hypoechoic is also suggestive of cancer. It is also suggestive of cancer, but the most they have asked most characteristic. In most characteristic, it is taller than white. Okay. If I ask you what is the feature suggestive of cancer on mammography? Mammography. See, if microcalcification would be the option, then they will not give this option. Okay, so it's not like questions are not made to harass you. Okay, so Pooja, don't think additional things. Okay, don't think too much. Okay, because suppose you would say, sir, all of these are options. Okay, so the question they don't make like this. They don't make like this. Okay, so all these are options. All these are features suggestive of cancer. But among these, the given option taller than white. Feature suggestive of mammography cancer is yes, microcalcification. What is microcalcification? What is the size in microcalcification? Yes, clustered, stippled, microcalcification. Yes, you are also to architectural distortion, asymmetry, and architectural distortion, irregular borders, or speculated margins. This is speculated. All these are not 0.2. It is yes, you are correct, Ayush. Less than 0.5 mm. 0.5 mm. Yes, 0.5 is correct. Dhruvi, yes, you are correct. So these are the features suggestive of malignancy on mammography. Okay. Next question. 40-year-old female, 10 centimeter right breast muscle. See, 10 centimeter. She notes that it has been rapidly growing and weight of the mass causes her right breast to rest lower than her left. Okay, pathology from the core needle reveals a fibroepithelial lesion with a notable leaf-like projection of the stroma. Which of the following statement is true of this lesion? What is this lesion? What is the lesion? What is your diagnosis? Yes, round irregular margin. Yes, you're correct, Sakshi. Oval is considered benign. Round is more of suspicious of malignancy. What is the diagnosis? Phyllodes tumor. Phyllodes tumor, also known as cystosarcoma phyllodes. I'm really surprised most of you are telling the answer very correctly. Maybe in the next session I have to put some difficult questions. I deliberately thought that okay, we should discuss something, but you know everything. That is like if you have read from me only, then this is a very you can say the proud moment for me that you know all these things. Okay, but believe me, many people, they will be confused and these questions might appear scary to them, and I'm very relieved that you find these questions easy and you are answering this. Okay, so phyllodes tumor, which is a fibroepithelial tumor. Okay, it is made up of epithelial tissue and stromal hypercellularity will be seen, and there will be hypercellularity, and there will be leaf-like projection. So from that leaf-like projection, the word phylloid has come. So this is true. Stromal hypercellularity is a pathological feature that distinguishes this lesion from fibroadenoma. In fibroadenoma also the same kind of thing is seen, but in phyllodes tumor, the stroma is more cellular as compared to fibroadenoma. Okay, as compared to fibroadenoma. So this is true. It is commonly demonstrates aggressive growth pattern similar to breast cancer. Okay, this is wrong. Why wrong? Because more than 90% of the time it is benign. More than 90% of the time it is benign, and rarely it is malignant. See, in this benign or malignant, how do we know it is benign or malignant or something? See, this is when we do the core needle biopsy. On the core needle biopsy is the investigation for this case also. When the number of mitosis is less than equal to 3 per 10 high power field, it is benign. And the number of mitosis is more than 4 to 9 per 10 high power field, it is borderline. And if it is more than 10 mitosis per 10 high power field, it is malignant. So remember, even if it is malignant, it will spread via hematogenous route. Hematogenous route to lungs. Okay, it does not go to the axillary lymph node. So that's why sentinel lymph node biopsy has become standard. That is not correct. We don't have to do sentinel lymph node biopsy because we know that even if it is malignant, it will not go to the axilla, it will go to the lungs. The addition of radiotherapy is recommended in most patients to prevent recurrence after lumpectomy. That is not correct. Okay, the surgery is, the treatment you have to do is, you will do a wide local excision with 1 centimeter margin. Maximum you can take is 2 centimeter. Mostly people, they take 1 centimeter margin. And if large, that is more than 10 centimeter, simple mastectomy. Remember, simple mastectomy. You don't have to do a modified radical mastectomy in this case. Radiotherapy may be given after simple mastectomy if recurrence occurs. Then you need to give radiation. Otherwise, radiation does not have a significant role in the management of Thyroid tumor. Can be confused with the aggressive tumor. No, it is never confused with the aggressive tumor. The thyroid tumor are very huge and generally they don't involve the surrounding things. They don't involve the skin. Even if the skin involvement can be seen late when the mass is very big, and because of the underlying pressure, it can cause the necrosis of skin. Then the ulceration may be seen. But believe me, looking at that ulcer, you can clearly say by just looking that it is because of the pressure the ulcer has occurred, not because of the malignancy. Yes, now in New Delhi it is given as 2 centimeter, but you can say like 1 to 2 centimeter margin is good enough. Okay, so option number 1 I will still consider as a better option. Surgical margin of at least, they are saying at least. Okay, you can say ideal. Ideally you can take 2 centimeter. 1 centimeter margin is also good enough. Okay, 1 centimeter is good, and we have done many surgeries with 1 centimeter margin. It is good enough. Okay, it at least, if it is 1 centimeter at least, then it would have been the correct statement. 2 centimeter is the ideal margin. So you can say margin के लिए you can say 1 to 2 centimeter margin. 1 is the minimum, 2 is the ideal. Okay, prognosis of malignant type is not very bad. Okay, as compared to the breast cancer, it is a better tumor. Okay, it is a better tumor. You can give chemotherapy and all later, but if you are asking prognosis of malignant type, it is better than a malignant or metastatic infiltrating breast cancer. Okay, so A is the best option here. Next question again, I am sure all of you, if you have read the topic, you will know MRI of the breast is best indicated in which of the following scenarios. Let's see, 45-year-old female, 1 centimeter area of microcalcification that is excised and pathology demonstrates atypical ductal hyperplasia, ADH. So atypical ductal hyperplasia, there is no need to do MRI as such, so no. 45-year-old average risk female with focal breast pain and a normal mammogram and ultrasound. Not required. Suppose here is high risk female. High risk may, yes, it is indicated. Average risk, it is not important. How to decide what to do? Wide local excision and simple mastectomy? See, if it is a benign phylloids or if it is a malignant phylloids. Benign phylloids less than 10 centimeter wide local excision. More than 10 centimeter simple mastectomy. Same is for this also. Less than 10 centimeter wide local excision. More than 10 centimeter simple mastectomy. But suppose in this case, benign case, after wide local excision, recurrence has occurred. Then what you will do? You will do wide local excision again. But in malignant case, after wide local excision, if recurrence occurs, next time you will go for a simple mastectomy. So I hope this is explanatory. Rishabh, okay, Rishabh, is it fine? Okay, yes, so what you are saying, all of you are saying C, all of you are correct. Infiltrating carcinoma found in the node and a negative mammogram and ultrasound. So this is basically axillary lymph node positive with unknown primary. Axillary lymph node positive with unknown primary. Microcalcification that are excised and DCI. DCIS we don't have to do. 45-year-old female, 1 centimeter microcalcification excised and lobular carcinoma. LCIS is not required. Okay, so one of the indication is this. The other indications, the important indication, differentiate between scar and recurrence after breast conservation therapy. In elderly with positive family history, mammography is better. Yes, it is better. Mammography is better in those females where the breast is more fibrofatty. So as the patient increases or advances in age, the breast will become more fibrofatty and it is definitely better. Okay, if it is multicentric tumor, high risk screening. Okay, like BRCA1, 2 screening. Implants. Okay, so these are some of the cases where MRI has a role. It is not routinely recommended. Yes, pregnant patient, if ultrasound is equivocal, it's not that in all the pregnant patients you have to get the MRI done. In pregnant patient, if ultrasound is very confidently says that it is cancer or not cancer, then you don't have to do MRI. Okay, so it's not indicated in all the pregnant patient. Pregnant patient, if the ultrasound is equivocal. Yes, multicentric means invasive lobular cancer, not lobular carcinoma in situ, invasive lobular cancer. MRI is more sensitive, but we don't have to do MRI just because the patient is having ductal carcinoma in situ. If there is extensive calcifications in the whole breast, then maybe in those cases we might have to do, but it is not that MRI we need to do in all the cases of DCIS. Okay, so 10 questions are done. One more question and we'll be half done. 48-year-old female evaluated for new left breast mass that was found on mammogram. She reports having 2 alcoholic drink per day. active smoker, 5 pack per year. Mother who was diagnosed with breast cancer at 65. Past medical history significant for atypical ductal hyperplasia, that was excised. Which of the following factors is associated with the highest risk of breast cancer in this patient? So you can see all the things which are given in this patient are somehow a risk factor. Starting from the female sex, starting from more than 35 years. Okay, she is like female, more than 35-year-old, and alcohol, more than 2 drinks per day. Smoking, although it is not very proven, but these days they say that yes, it increases the risk. And a first degree relative with breast cancer, atypical ductal hyperplasia, all these are risk factors. All these are risk factors. So they are asking which is the highest. Yes, smoking is not yet confirmed, but most of the books now they start writing smoking. Okay, so let me tell you, alcohol increases the risk, 2 times increase risk. Smoking is not yet sure, but yes, first degree relative with breast cancer, again you can say 1.5 to 2 times increase risk. Atypical ductal hyperplasia, 4 to 5 times increased risk. Lobular carcinoma in situ, 8 to 10 times increased risk. So E is the answer here. Okay, none of you had said this. This is okay. In this question, I win. Okay, up to 10 questions, you all were winning. This is my time. So E is the answer. Atypical ductal hyperplasia, atypical lobular hyperplasia increases the risk 4 to 5 times. Okay, says 5, like I said, first degree relative with breast cancer, 1.5 to 2 times increased risk. Atypical ductal hyperplasia, lobular hyperplasia, 4 to 5 times increased risk. This is the answer. Okay, so just being a suppose in this case, if you ask me overall among all the risk factor, the maximum risk is if the patient is BRCA1 or 2 positive. That is the maximum risk if the patient is BRCA1 or 2 positive. But as it is not in the option, so we have the best answer is history of atypical hyperplasia. No, you don't have to memorize the percentages as per ratio, but you need to remember that those things are not as bad as this thing or this thing or this thing. Okay, so these are the like high risk factors: BRCA1 or 2, atypical ductal hyperplasia, lobular carcinoma in situ. These are more more severe risk factors, and rather than the alcohol or first degree relative. Okay, so hope you understand what I wanted to ask in this question and what I wanted to tell you from this question.